Well, hello, everybody. Welcome to this episode of Infection Control Matters. It's Martin Kiernan here, and my special guest today is Helen Dunn, who's consultant nurse at Great Ormond Street Hospital in London. She's working in infection prevention, where she's worked there for at least 10 years, I think, and was at a period before. So welcome, Helen. Thanks very much for agreeing to chat to me.
Thank you. Thanks for having me.
Now, what piqued my interest is a paper that Helen and colleagues, including Elaine Cloutman-Green, who's previously been on the podcast, had published from Great Ormond Street, looking at ward rounds as a method of giving education in infection prevention. This is a different slant on it. It's a small, if you like, precursor piece of work, and it really piqued my interest because I spent years trying to do education, I call that, mandatory training, so everybody gets dragged along kicking and screaming. Interestingly, as part of an educational thing recently, I put up a slide saying, could you give me one word that relates to what your experience of infection control education was? And the major one was frustration, boring, all that sort of stuff. And unfortunately, that was from the people who are actually delivering the education, not those sitting in it. So if we can't get enthusiastic about it ourselves, then we have no chance. But this is looking at it in a different way. This is about going out, engaging with people on the ward. So Helen, what firstly made you think, actually, maybe we need to go about our education in a different way and try this approach, and then describe the approach, if you don't?
To be honest, most people will know me for the gloves off work, which began at Great Ormond Street in 2017. And it's probably that first piqued my interest, because that work was done with, I did that work together with two educators, Nicola Wilson and Amy Leonard. And they're both clinical educators, paediatric clinical educators. And it was just fascinating seeing the way that they structured content. We kind of brought all the work together that we did around gloves off. And we're not here to talk about that today, but we brought all the work together. And then they structured it in a way that was delivered towards staff that was quite different to what things that I had seen before. So my typical experience of infection control education had been delivering it and receiving it, similar to what we both know, standing in front of a classroom, telling people what they needed to do without really understanding what the barriers might be in practice and things. But they asked some really interesting questions. We tried to keep the information we gave staff really evidence-based so that we could empower them to make decisions. And we also had a period of time where we delivered the education and then asked for feedback. And we released a set of FAQs as we went live. And that was based on all the feedback we'd received on our education, what we hadn't covered it in, and what questions people had about that in practice. So that was the first time I'd really seen that. And then it sort of surprised me as Gloves Off went on and kind of continued through the pandemic, how successful it was at Great Ormond Street and how there was a real culture change around an infection control intervention that really seemed to have been delivered quite successfully.
That's rare.
It made me think maybe there's a different way. Maybe I need to look at how I deliver education. So it kind of drove me to go and apply for an apprenticeship to do a postgraduate certificate in clinical education, because I wanted to go and learn how to deliver education in the same way that Nicola and Amy have been structured to deliver it. So I went and did that at the University of East London, and it was probably the most fulfilling course of my life, because it was almost that final piece in the jigsaw puzzle about how people learn, the different learning needs, how to set up a session if you're going to deliver it. So I'd never really understood before I did that course that actually, you needed to have your learning outcomes and your method of assessment before you wrote the content of the course and things. So it made sense. Whereas before I sort of fumbled through content and then cobbled together learning outcomes and stuff. So it really changed how I thought about delivering infection control. And this was actually a project that I did for one of the modules within the postgrad certificate of infection control. And I wanted to just explore if there was a different way to deliver education. So I worked with a team on one of the wards at Great Ormond Street to kind of come up with this model. And what I realised quite quickly is if there wasn't a framework to talk around things with people, then it could be, if you ask someone, have you got any problems? Their answer is always no. So I had grown up,
yes.
We were chatting just before the podcast, and Martin was saying that he used to go around the wards and have you any problems, try and touch base with people. And I was taught exactly the same way at Frimley Park when I did my postgrad certificate in infection control. And actually, people sometimes didn't feel confident to ask questions. So I wondered if I created a framework, and it's a bit basic really, but almost a point of conversation around each patient. If I was able to do that with the nurse in charge and go with some questions, would that generate questions, and would it improve outcomes and improve relationships, I guess, because infection control is a lot about relationships. So that's kind of where it came from.
So you talk about a framework, because I agree, go on the ward, have you got any problems? The answer is no, because they want you to get the hell out as quickly as possible, rather than just standing there chatting to them, or even looking around and spotting all the things that you might then pull them up on. So talk to me about just the simple questions then, and the simple framework you put together for this. And this was a ward round you would do with the nurse in charge on that shift, is that right?
Yeah, so the way we structured it is that I went up 3 times a week. One of the things that we do slightly differently at Great Ormond Street is we screen all of our patients on admission, and every 30 days for MRSA and stool screening. And we also try and, obviously, because we're paediatrics, lots of children have lots of viral infections, be that gastro or respiratory. So we try and, they're often in and out of isolation for that reason. And sometimes there's a delay in either putting them in isolation, recognizing they've got symptoms, or stepping them down as well so they can return to normality.
Yeah.
So I kind of based the tool around what I knew roughly the problems were, and I wanted to make it an acronym so I would remember it. I thought it would sound cool for a paper. So I came up with SALT, which was screening, because that's our number one problem, I guess, making sure the screens are done. Assessment of any new symptoms was my A. Reviewing lab results. So what they quite often didn't do was review lab results to step children down, or review lab results to know that a patient who was going for some type of surgery was MRSA, and did we need to decolonize them before a line went in, or those types of things. So reviewing the recent lab results. And then T was my transmission-based precautions. So just making sure they were in the right precautions. So either stepping them up or down as needed. And I kept it as simple as that in the first instance. We have used it since and kind of adapted it and put different things in, because I thought you could almost, if that was something that was working really well and the admission screening on that ward and management of symptom-based recognition went well, you could always change it up and have something around lines if you had a particular issue around central line documentation or things on those wards. So I think it's like almost a framework that you could switch and adapt depending on what
drop in a section or out, because some boards will have more central lines than others, won't they, presumably? And that sort of thing.
Yeah, exactly.
Okay. So you got your framework, you're heading for the ward. I mean, you're generally going for what was a band 6 nurse who's been qualified about 3 years and who would generally be the lead on that particular shift.
Yeah.
How are you received at the time? Because often you get, I've not really got any time, and could you come back later, or I'm a bit busy.
Yeah.
What was the reception like?
So the first time I did it, I have to be honest and say it didn't go well, primarily because it took too long. So the thing that I realized is it needed to be relative. I mean, this was a 26-bedded cardiac ward, but this needed to be quite quick and something that could be done in 5-10 minutes max, unless they had, huge issues. But that was, I wouldn't say partly my own fault, wasn't my own fault at all. But I had a vision, because we've got an electronic patient record, that we would grab a computer, go around and review all this together. But clicking in and out of 26 patient notes beforehand didn't really work that well. So what I realized quite quickly is if I'd gone through the patients beforehand, so I did myself almost a template and actually knew this patient needs a screen, this patient needs this patient, it says, you sent this sample, why have you sent it? If I'd prepared myself with those patients and I was going up 3 times a week, traditionally kind of on a Monday, Wednesday, Friday, then I knew those patients. So it was quick once I got to it. But as soon as I started doing that, they were actually, I think I say in the paper, maybe I do that, I was quite surprised that the reception, people found it really helpful. I think they started to see how quickly we could get results, the improvement around screening. If patients were negative, we could step them down out of isolation if they were asymptomatic, whereas before it almost was just this nebulous that they were a bit afraid to, change the isolation status, etc.
I mean, generally people have got to have a what's in it for me. So they were seeing advantages, like they were getting better information, they were actually moving patients more efficiently, that sort of stuff. So there was a tangible benefit for them in some ways then.
Yeah, and then it kind of developed that actually questions would be asked. So we had like a patient who was exposed to chickenpox during the time, I remember. So there was a whole question about, oh, well, we need to isolate the patient straight away. And no, chickenpox has got an incubation period, so you're okay until this day. No, 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 we need to do it now. No, you're absolutely okay. Look, this is the evidence and this is the guidance. So it was almost sort of an informal teaching opportunity that worked well. And I think people respond to education better if they can link it to a scenario that's real life rather than just chicken pox is
Yeah.
infectious after X days. So
Yeah.
it seemed to work well. And we did similar things. I think we had a PVL MRSA at the time as well. So we talked about how to decolonize them and the family and make those risk assessments. So it became, yeah, pretty useful.
Yeah. Did you find any interest from other members of staff actually listening in?
Yeah, absolutely. So the odd nurse would kind of poke their head around the corner and say, oh, I've got a question about this, or the healthcare assistant would ask questions and things. And because obviously we're a children's hospital, we even had parents asking questions, or what are you doing? What are you talking about? And explaining to them was also helpful because they're such an important part of
certainly
care
in paediatrics.
for their children.
I mean, interestingly, you were saying beforehand you wanted to get away from this, the infection control, infection prevention team being the police. I would see this as a step as to turning you into the fire brigade, where people are actually pleased to see you turn up and know that you're going to be involved in prevention or sorting out the problem, rather than coming to tell them that here's all the things you're doing wrong. Did you start to get that impression where people are actually seeking you out a little bit more?
Yeah, I think the nicest thing that was said by one of the nurse in charge, who's now sort of a junior sister, and I remember him saying it, was he goes, I said, oh, any feedback on what could be better? He goes, this is fabulous. It's just like resus training. It's like just in time training, what we need to know just in case. And I thought, I've never heard infection control spoken about in that way. Normally, you hear infection control training, and like you said, people roll their eyes or feel quite frustrated.
Yeah.
It was a little bit of extra work to prepare the stuff to go up there, but kind of the rewards were worth it, I think.
Yeah, I mean, you may find if you'd done the longest piece of work that the amount of prep time would have decreased because there'd been less issues.
Yes.
What I did think was interesting is you evaluated it in two ways. You did a quantitative piece of work and a qualitative, and this to me shows the value of doing both, because it's easy to go down one route and then not find out a bit more detail about the effect. So can you talk me through the two types of results that you got?
Yeah, so the quantitative was a disaster, to be quite honest, which because people are not very good at filling in surveys, is what I found. Even with bribes of biscuits and other things, not for the results, but just to fill it in. So yeah, the quantitative didn't really work, and I am really interested in qualitative.
Me too.
Or doing qualitative studies related to infection control. So I wanted to try something using a mixed method, kind of QI methodology. So I wanted to make sure I had both, which was the reason that I did both methods. But actually, in retrospect, although it would have been better for me to have done the quantitative, that actually the person who I did the ward round with, given them the questionnaire at the time that we were doing it, or something like that, to make sure that they did it. That could have been a better way to have made sure that was more
next
effective.
time, though, couldn't it? That could be done.
Yeah,
next time,
of course.
Yeah.
But the qualitative data that I got was really useful. And I kind of wrote, I wanted to have a shot at writing a sort of reflective journal at the time, because I knew that all the ward rounds would kind of mix into one. So what I did at the end of each session is I wrote down how it had gone, and then I attempted in the paper as a first step to theme it with the main themes that I'd found. And I just found that really helpful, because I think it's easy, every day sometimes becomes the same, and it's difficult to remember the different interactions you have with everybody. So I wanted to be able to pull out what were the main areas we spoke about, how was I received, and I was pretty much welcomed. People were pleased to see me, which was
said almost no infection control nurse ever. So tell me about the themes. What did you come up with?
So definitely education was the key thing that came out. I had 4 main themes. So education was one of the top things. So always, in almost every interaction I had, I delivered some form of education, be it around how to take a stool sample, how to take an MRSA swab, how to, assess a patient So that was it was definitely a method for delivering education that appeared to work.
Rather than instruction. That's interesting, because often we would go in and say, put them in the side room, do that, do that, do that. But your predominant theme was actually this is done in an educational format rather than an instructional. So people are understanding why, I suppose.
Yeah, and a collaborative format, I think, because I think
Yeah.
Elaine will talk. She's been on the podcast before, but Elaine and I work really closely together. And Elaine talks a lot about risk assessment being a fundamental part of infection control. But
Yeah.
if we don't discuss with staff how to risk assess and include their risks in our risk assessment, then it's a bit not really doing a good job. And welcoming is on there because I think I wanted to show that infection control can be a valued member of the team. I think sometimes like we're all quite fatigued after the pandemic, and it can feel like quite an exhausting job emotionally because you're always asking people to do extra on top of what they're already doing. But I think it is a good opportunity for us to get positive feedback from staff, which in turn makes us feel valued as well.
Yeah.
So I found that really helpful. I did get a fair amount of feedback, about half the time, from the nurse in charge. This has been really helpful, thank you. Those types of things. And they also began, not all the time, but they began to highlight kind of things that were issues in practice. So if I was suggesting something, they'd be like, actually, that's really difficult for us to do. And they would tell me why, which was helpful, because I think it showed that they trusted me and trusted the process, but also that they felt confident to say, we're learning from them in practice as much as they're learning from us. We just might be the specialists in preventing infection, but they're the specialists in delivering care for those children. So we wanted to make sure that they felt that we were learning as well and changing our guidance.
I think that's a really good point, because they are experts in that particular area. I've gone on to intensive care. I've never worked in intensive care. I have worked in theatre. I have worked in orthopedics. I haven't done endocrinology. So the people working in those areas are experts in those areas. And I think for us to be seen as learning from the staff is always a very positive thing, I think. And also, you're going to come across situations where you are not familiar with, and you're going to have to solve the problem yourself. So do you think that helped your problem-solving skills as part of this?
Yeah, I think I've got pretty good problem-solving skills anyhow, to be honest.
No, but you're quite senior, though, Helen. I mean, a more junior nurse might find that more useful.
Absolutely. And I think it was really eye-opening to think that actually infection control sometimes doesn't have all the answers. Sometimes you can give us a problem and we can go away and we can think about it and come back to you with what might be a suggestion, and you tell us if that's okay. Because I might be senior, but I don't have all the answers, but I can go away and think about it. People quite often say to me at work, they normally tell me a problem sort of at least a week in advance and when we're going to talk about it, so I can go away and think about it, because we're not, I think we almost, particularly from the pandemic and even before, probably have this view that you'll tell us a problem and we'll instantly know the answer or what to do. But this infection control is so vast and broad that you have to go away and think about it, don't you, quite often?
I really couldn't agree more. And yes, you could give an answer straight away, but it may not be the answer. And then going back and undoing what you said a week later, I think some find tricky. I mean, I have no problem going back. Do you know what? I said that a week ago, but on reflection, I think this, and this. I've got no problem, because I love being wrong. You learn stuff and people see vulnerability. But a lot of people go, oh, we better not go back on that, because people might think we're a bit weak, or I don't know, really. Where do we go with this then now? Are you actually doing this at all in the hospital now? This is a piece of work you've looked at. Is this something you're maybe rolling out, or how do you see it going forward?
Yeah, we have definitely used it since, in specific circumstances. We've had, just really due to kind of like operational reasons, we haven't rolled it out per se. We're doing a separate piece of work at the minute, though, which doesn't use this exact methodology, but we're doing a QI project to reduce specimens at the moment. And one of the things that I was really keen we did is, when we implemented it, we phoned the wards and had a discussion. So we were trying to sort of like reduce the amount of inappropriate specimens that were sent, particularly relating to virology. So not massively important in lots of other hospitals, but for us, it's a huge issue that once someone's tested positive for a respiratory virus, people just send lots and lots of tests. But in order to roll that out, one of the things we wanted to do was, rather than just tell people or put the change in Epic, we've actually done it so that we call the wards and have a discussion, or go to the wards and have a discussion with the teams about, is this test appropriate, why it's not, show them the guidance, rather than a change that's either just, sent out and off you do it. Because I think what we learned from this is that people respond much better and remember if they've been told by a person.
Especially if they've been told why. I mean, I don't suppose you've been able to measure that at all, have you? Because, I mean, the lab would presumably be able to chunk out a number of tests done.
How many we've saved so far?
Yeah.
So we were live. So, I mean, this is very early data, but since 2 weeks since we went live, we think we've at least reduced, if we had 80, we'd reduced it to 60 within a week. So, yeah.
That's a 25% reduction. So, I mean, that's significant, isn't it? Therefore, cost saving, therefore arguing for more members of your team. Because it's really about time we started to show ourselves as cost effective, though, isn't it? Saving the organisation money and making it run more efficiently. We're not great at doing that.
And I think, the way that we spoke about it with staff is that, it's not a very nice test for the most part for children to have a nasopharyngeal aspirate. It's an aerosol generating procedure.
Yeah.
It takes at least 10 minutes of a nurse's time. And like the sustainability impact of what that costs, like from a plastic point of view on the wards and in the laboratories.
Yeah, or the PPE, etc. Yeah. Yeah, I mean, it's not just the cost of the test, is it? It would be quite interesting to quantify that.
We have got some initial costings that we're going to sort of work up in the run to Christmas and then sort of come out with that. But so I think we are using it. And one of the things that I'm really keen to do is to do more qualitative infection control work to understand the why, because I think we're very good at identifying a problem and putting a solution in place, almost a bit of a like rescuing scenario we have going on, that we try and find a problem and fix it. But I'm kind of the opinion now that maybe we need to think about why things are happening, and perhaps the right thing to do. There's some interesting work coming out from King's College, from Anne-Marie Rafferty, and things around nurses' workload, and potentially that taking away could actually improve safety. So I'm interested to explore that and see if that's something that actually, rather than giving people something additional to do, and I guess that's what we've done with the virology, we're actually saying, here's one less thing to do and here's the reason why. And does that actually therefore improve safety and infection control?
Oh, you are going to be very popular then if you're taking things away from people. Helen, it's been fantastic. Thank you. I really enjoyed the paper. I really enjoyed chatting to you. I may put a soundtrack over the back of you talking about the way we learn of choirs of angels singing, because it fits very nicely in with what I've been thinking for a number of years. Because I did years of mandatory training. I have no idea if it had any impact whatsoever. And here you're getting something a bit more measurable potentially.
There is just one final thing I'd say, if that's all right, just to kind of get it out there. So one of the things I talk about in the paper is Schulman's signature pedagogy. And that's really interesting, because if people look that up, that's actually particularly how doctors are trained. So it talks about a surface level, a deep level, and then kind of this intuitive level of learning. And actually, we don't do the same thing in nursing, which was really interesting. So I attempted to try and say, should we be using this type of, why are we trained differently from doctors? Should we be trained in the same way? Should we have those 3 levels? Yes, we know what to do. Yes, we know why, but what are the behaviours that make sure we do it? So I just think that's an interesting thing for people to go away.
Presumably that doesn't apply to hand hygiene with doctors then. They haven't twigged that one.
Some, yeah.
Okay. Well, I mean, I'm going to go and look that up, and I'll stick a link to that in the podcast, and there'll also be a link to the paper as well, so people can read the paper and have a listen to this and see what they think. Thanks very much for joining me, Helen. I'm really grateful, and bye, everybody. Catch you on the next episode of Infection Control Matters.